Hello, my name is Dr. Keith Crawford. I'm the Director of Clinical Trials and Patient Education at Prostate Health Education Network. Today, I'm here with Dr. Cora Sternberg, who is the Clinical Director of the Englander Institute for Precision Medicine at Weill Cornell Medicine in New York, and Dr. Michael Haffner, who is a pathologist specializing in genitourinary pathology at the Fred Hutchinson Cancer Center in Seattle, Washington. Hello, everybody.
Hello, we're glad to be here today.
Happy to be here.
We will be discussing the importance of precision medicine in prostate cancer and genetic biomarker testing, and any common misconceptions and barriers healthcare professionals may believe and face when implementing biomarker testing in their practice. Dr. Sternberg, Dr. Haffner, is there anything that you would like to state up front about this topic?
Yes, biomarkers are becoming increasingly important to help guide overall patient assessment, diagnosis, care, and management. We now have the ability to help identify actionable tumor targets to personalize treatment for patients with prostate cancer. Biomarker testing is essential for our patients with prostate cancer, as not only does it impact the care we can offer our patients, but it also provides invaluable insight into their disease prognosis and likely outcomes. In prostate cancer, we can use germline testing to identify inherited alterations and somatic tumor testing to find acquired alterations, since prostate cancer is a heterogeneous disease. I want to mention something about homologous recombination repair, or HRR genes. These are genes such as BRCA2, BRCA1, ATM, CHEK2, and PALB2. You'll be hearing a lot about these. And mismatch repair, or MMR genes, such as MLH1, MSH2, PMS2, and MSH6. These are other examples of germline inherited alterations in prostate cancer. Now, HRR genes are genes that tell cells how to repair damaged DNA. Therefore, if you have alterations in these genes, it makes it difficult for cells to repair their DNA. DNA mismatch repair, or MMR genes, are genes that maintain genomic stability by fixing mismatches created during DNA replication and recombination. Evidence-based guidelines recommend germline and somatic testing for HRR genes in patients with metastatic castration-resistant prostate cancer. Yet despite this, real-world studies have found that only 26% of eligible patients actually receive HRR testing. Although there are barriers to patients receiving biomarker testing, it's important for healthcare professionals to make the effort to understand and to recommend biomarker testing to all eligible patients with prostate cancer. This may help improve testing rates and consequently increase the number of patients with prostate cancer who can access biomarker-specific therapies.
From a pathologist's point of view, analyzing biomarker testing results helps us to provide recommendations to physicians about appropriate treatment options and potential next steps in a patient's medical journey. As mentioned before, there are two types of biomarker testing that can be utilized to identify alterations in genes, including HRR genes, which are commonly altered in prostate cancer. The tests are germline and somatic tumor testing. So let's start with germline testing first. Germline testing analyzes inherited gene alterations that are present in all cells in a patient. Blood or saliva samples can be used for this type of test. Now, somatic tumor testing analyzes acquired gene alterations that are present only in tumor cells. A solid biopsy takes tissue from a tumor directly, while a liquid biopsy analyzes the blood for the presence of circulating DNA shed from tumor cells. Circulating tumor DNA, also known as ctDNA, is becoming increasingly used. The gene alterations present in a tumor cell may differ from those identified in germline cells.
Thank you both for your input. Before we dive into this topic, it's important for people to understand the purpose of biomarker testing. Dr. Sternberg, can you expand upon why physicians should offer biomarker testing to their patients with prostate cancer?
Biomarker testing has prognostic value in prostate cancer by determining if a patient is predisposed to developing a more aggressive disease. The presence of BRCA1 and BRCA2 alterations are associated with an increased risk of prostate cancer, as well as onset of cancer at a younger age, an aggressive clinical course, and even increased cancer mortality. Furthermore, germline testing can determine whether a patient's prostate cancer is hereditary. And this can be important in informing family members about potential gene alterations they may have inherited, particularly if any of these may increase the risk of developing cancer in the future. Patients or their family members who are identified to have an inherited BRCA1 and/or BRCA2 alteration could benefit from prostate cancer screening, since, as just mentioned, alterations in these genes have been associated with an increased predisposition to prostate cancer. And in particular, BRCA2 alterations have been associated with a 2 to 6-fold increase in an individual's risk of developing prostate cancer. Outside of BRCA1 and BRCA2 alterations, and although the evidence is more limited, patients with germline alterations in ATM, CHEK2, or PALB2 may also have an increased risk of prostate cancer.
So now that we understand the difference between germline and somatic tumor testing and why biomarker testing is important, Dr. Sternberg, can you tell us about who you typically consider for biomarker testing at your practice? And what is the general consensus on the optimum time to conduct biomarker testing?
That's a great question, Keith. The consensus on which patients should receive biomarker testing differs according to whether we're conducting germline or somatic testing. For germline inherited biomarker testing, there are established guidelines which recommend testing patients with a positive family history of certain cancers, such as, for example, prostate cancer, breast cancer, ovarian cancer, or pancreatic cancer, and also patients of Ashkenazi Jewish ancestry. The guidelines also recommend germline biomarker testing in high to very high risk, localized, regional, meaning cancer that has spread to nearby areas of the body, or metastatic patients, meaning cancer that has spread to distant areas of the body. For somatic biomarker testing, there are also established guidelines which recommend testing tumor samples for alterations in HRR genes from all patients once metastatic prostate cancer has been confirmed. And healthcare providers should consider testing for these genes also in patients with high-risk regional prostate cancer. In relation to other genes, these guidelines recommend tumor testing for microsatellite instability or deficient MMR in the metastatic castration-resistant prostate cancer setting, and that patients with regional or metastatic castration-sensitive prostate cancer should also be considered for such testing. Patients with metastatic castration-resistant prostate cancer may also be considered for tumor mutational burden testing.
So as we know, testing rates remain suboptimal, and therefore patients may have already been diagnosed with prostate cancer before biomarker testing is offered to them. So based on this, there's this misconception that biomarker testing is not relevant post-cancer diagnosis. Dr. Sternberg, can you explain how biomarker testing results can impact the patient's care plan and their treatment journey, and even after they've been diagnosed with prostate cancer? Similarly, Can you also explain, as an oncologist, how you can use biomarker testing results to manage the care of your patients with prostate cancer?
The treatment landscape for prostate cancer is constantly evolving, with novel biomarker-specific treatment options emerging, making it essential that we keep biomarker testing at diagnosis and throughout a patient's prostate cancer journey, especially looking for acquired alterations so we know which patients will benefit from these new novel therapies. As mentioned, certain HRR alterations can sensitize tumor cells to biomarker-specific therapies, and thus the results of biomarker testing can influence the medications I recommend to a patient as part of our shared decision-making process. Since the therapeutic landscape for prostate cancer is so dynamic, biomarker testing can still benefit patients who are not initially offered testing when they were diagnosed, as it may highlight them as a potential candidate for a therapy they previously would not have had access to, and which could ultimately slow or halt their disease progression. What's more, if germline biomarker testing is performed, results can also help patients inform their family members of potential gene alterations that they may have inherited and explain how these may affect their risk of developing certain types of cancer in the future. This is called cascade testing, and it's important for all direct family members, children, brothers, and sisters.
Now that we have an understanding of the role of biomarker testing in a patient's cancer's journey and which patients are eligible to undergo it, I think it'd be helpful to explain the technicalities behind biomarker testing on a scientific level. Dr. Haffner, how do you choose the right technology to conduct biomarker testing? And what type of sample do you use?
So there are several large multi-gene testing panels available for germline and somatic biomarker testing, which test a broad range of genes, including HRR genes and other actionable cancer genes. Regarding the sample type, as mentioned previously, germline biomarker testing uses blood or saliva samples, and somatic testing analyzes tumor tissue or blood for gene alterations. So let's start with germline biomarker testing. Some factors to take into consideration are that there is not a significant difference between saliva or blood samples. However, saliva samples have a lower DNA yield, which may impact which methods is being used when performing germline testing. For somatic biomarker testing, liquid biopsies, that means just getting a blood sample, tends to be less invasive. However, the timing of sample collection, especially before a patient starts responding to therapy, is important to ensure a high yield of tumor DNA. Solid biopsies need to be performed on a site where a tumor tissue sample can be extracted, which makes it difficult to obtain in certain anatomic locations. In the event that obtaining a solid metastatic biopsy is unsafe or unfeasible, the guidelines recommend a liquid biopsy as an option.
So considering how heterogeneous prostate cancer is it possible for a patient's biomarker profile to change or even evolve over time? If so, does a patient require a new biopsy further along their treatment journey?
Well, for the example of HRR gene alterations, we tend to think of these as truncal for the majority of patients, affecting all tumor cells. However, there is a possibility that a patient may receive a false negative result from biomarker testing, especially if a sample is old or there's low tumor burden. Additionally, distinct clonal tumors may be present in prostate cancer, harboring different types of alteration. This can result in a patient not receiving optimal therapy, which can affect their treatment outcomes. In addition, it's also possible that in some patients, their genomic landscape can evolve over time, especially after receiving therapy. Retesting of somatic alterations may be required to ensure a patient receives the correct test results following disease progression. Patients should discuss their test results with a genetic counselor. However, most community practices do not have a genetic counselor on staff. And in those instances, appointments with genetic counselors may be arranged.
So based on this discussion, it's clear the role that the healthcare providers have in biomarker testing and supporting the patient through the process. But there is this interdisciplinary aspect to it. Can you both explain the role of the medical oncologist and the pathologist in biomarker testing? And really, how do you work together? Also, explain what happens once a patient is referred for testing.
Yeah, so in pathology, we perform biomarker tests on blood, saliva, or tissue samples and analyze the result. Based on what we conclude, we can then notify the oncologists about the result and help guide treatment decisions.
Oncologists are the ones who most often refer patients for biomarker testing. Whoever orders the biomarker testing should understand the requirements of preparing the samples as well. As Dr. Haffner mentioned, oncologists, pathologists, nurse practitioners, and genetic counselors, when available, can have conversations about the results and discuss potential treatment options and next steps. During the follow-up visit after biomarker testing, a multidisciplinary team, if possible, is often involved. I would have a candid discussion with the patient about what their results mean and how it will impact upon their treatment journey.
To wrap up today's discussion, Dr. Sternberg, what would you consider to be some of the biggest challenges in implementing biomarker testing? And how would you unlock the potential for more personalized treatment options by improving biomarker testing rates and implementing biomarker testing so that it becomes a part of your routine clinical practice?
I believe a lack of awareness of the benefits of biomarker testing and uncertainty about which patients to test for biomarkers are some of the biggest challenges in our field today. This leads to physicians not recommending testing to their patients who could otherwise be eligible and may greatly benefit from testing, resulting in low testing rates. Like we mentioned, with only 26% of patients with metastatic castration-resistant prostate cancer undergoing biomarker testing. Another challenge to biomarker testing is cost. There's also other barriers such as lack of access to testing laboratories, and there are very few genetic counselors available in this country. There's also unfortunately, a racial disparity in biomarker testing across minority groups, especially Black patients, who are 1.7 times more likely to be diagnosed with prostate cancer compared with white patients, and are approximately 2 to 4 times more likely to die from prostate cancer compared with every other racial and ethnic group. Studies have also shown that the use of molecular markers for risk stratification led to higher risk classifications for Black men with low and intermediate risk prostate cancer, suggesting a need for increased use of biomarker testing in Black men, and that biomarker testing in Black patients may better help us inform their treatment plans. Mike, maybe you'd like to comment on some of the challenges for biomarker testing from a pathologist perspective.
Yeah, thank you. The quality of the sample, including a high cell or DNA content, is really absolutely key. But it's important to note that even older archival samples can still be used if they're of adequate quality. Prostate cancer patients often have only bone metastases, and sampling bone metastases can be exceptionally challenging. So it's therefore important to obtain an adequate sample and to follow validated processing protocols. In this context, I really think it's important to raise awareness about the ease of liquid biopsies, these ctDNA-based assays that we were talking about, for testing, because they can be helpful to increase biomarker testing rates.
That concludes our episode today discussing the importance of biomarker testing for patients with prostate cancer and debunking common misconceptions and barriers surrounding it. Dr. Sternberg, Dr. Haffner. Thank you for taking the time today to discuss this very important topic. I think we can all agree that biomarker testing can impact a patient's care plan and influence their treatment pathways. It's important to have biomarker testing to determine a patient's eligibility to take advantage of targeted therapy for patients with prostate cancer. We hope you tune in for our next episode where we join Dr. Sternberg and Mike Crosby. Now, he's a United States Navy veteran, prostate cancer survivor, and founder and CEO of Veterans Prostate Cancer Awareness. Now, what we're going to do is talk about the journey of a patient with prostate cancer diagnosed with a BRCA2 alteration and the role that the healthcare providers have in helping guide their patients through the biomarker testing process.